Welcome to It Comes in Pints, a Seattle Study Club podcast where we will explore a myriad of topics: clinical, health and well-being, psychological, education, business, and much more. I'm your host, Greg Tice.
I am Dr. Amy Doneen, and I have been doing arterial health and cardiovascular prevention for about 24 years now. And I carry kind of two hats to my life. My day-to-day hat is I see patients, and I see patients Monday through Thursday in the prevention center that I've owned since 2004. And it's a great journey. And I was seeing some patients the other day, and I realized that I'd started seeing them in 2002. So it's just crazy to kind of look at the time. And like dentistry, I see these people every 3 to 4 months, and for 24 years, basically. It's just, I'm so honored for that. So that's what I do day to day. I own and operate this center, the Prevention Center for Heart and Brain Health. Then my other hat is I'm a co-owner with Dr. Bradley Bale of the BaleDoneen Method. And we've been doing this method to teach people about what we're learning clinically on how to identify disease early in the artery wall, ask what causes it, measure the inflammation, treat the inflammation, see the disease stabilize, and prevent heart attacks and strokes and microvascular disease along the way, which probably over the last couple of years has been a huge focus of ours because, we have so many arteries in the body, and if we're protecting the big ones, by default, we're protecting the smaller ones. So it's been a really great journey that continues.
And we'd like to welcome everyone to the latest episode of It Comes in Pints, a Seattle Study Club podcast with your host, me, Greg Tice. And we are blessed today to have the famous co-developer of the BaleDoneen Method, really a risk assessment kind of treatment protocol aimed at preventing heart attack and stroke, right? And many of the folks in our network know you through your teaching, know you through your publishing. But this, I really want to be a pub conversation. We're sitting having a beer together. And in order to do that, we actually have to have a drink. So what have you brought with you today to drink with us?
Well, I brought coffee, which I love. And it's got a little cream in it, about the same color as my shirt now that I look at it. But what's more interesting is this cup. I collect pottery, and this is one of my favorite pieces, and I found this little gem at a tiny little coffee shop in a turret of a castle in Estonia.
Oh my goodness.
Years and years ago, and it's still one of my favorites. So coffee and beautiful pottery.
Oh, excellent. Well, I am in the same vein, having coffee, but mine has been distilled with a little bourbon.
Okay,
so it's cold brew and bourbon, but we'll have fun either way. So
I love it.
Cheers, by the way. Cheers.
Cheers.
And as I mentioned, many of our members, many Seattle Study Club members have heard you present, know who you are and what you do. And really, honestly, at some point, the rest will hear you when you present your keynote at the symposium this coming January in Marco Island, Florida. That's a shameless plug. But here's where I'd like to start. I want to go back a little bit. When did you know that medicine, healthcare was what you wanted to pursue, that was your mission or your call? Was there an aha moment, and when was that?
Yeah. So I think, yes, there was a definite aha moment. And my background, Greg, is different than most in that my doctorate is in nursing. And so I'm a DNP. But my journey started a long time ago, started off with working as a nurse, right? And that was back in 1994. And what quickly got me was the lack of autonomy. And I had a lot of interest in health in general. And in nursing, there's so many different areas you can work in. But when I went back to get my master's, my nurse practitioner, and then my DNP doctorate from Gonzaga University, I had met Bradley Bale along the way. He was doing family practice, okay? And
Okay.
he was one of the few people
In Spokane? He was doing it in Spokane?
Yep, he was one of the few people. There was another gentleman, Dr. Paul Shields, and Dr. Pierre Leimgruber, who were interested in identifying disease before someone had a heart attack or stroke. And the technology we had back then was a coronary calcium scan. Right, that's all we really had. So my original thesis work was, I wanted to know how many people were identified as great, like with our standard, and it hasn't changed. That's the problem. Our standard Framingham risk score: age, gender, smoking status, total cholesterol, systolic blood pressure, and basically just a few simple points. And how many of those were told they had low risk for a heart attack or stroke, less than 1% chance of having a heart attack or stroke in the next 10 years? How many people had a heart attack, number one, and how many of those people had plaque in their arteries and didn't know it? And so that was my original interest, and it's been a journey along the way.
All right, so you did your doctorate at Gonzaga.
Yep.
Why Gonzaga? Are you just a basketball fan? I'm teasing you because my son went to Gonzaga, but
Love it. Well, it's here, and
Yeah.
Interestingly enough, they had just started their DNP program. I was the very first one to graduate from that program, which is really interesting because I wanted in, and so I raced through it. But yeah, so Gonzaga, and yeah, I do love basketball. I have season tickets to the girls.
Oh, you do? Awesome. You kind of have to be if you're there. So
Yeah.
it's a requirement. Okay, so you got your doctorate. When and how did the BaleDoneen methodology come together? BaleDoneen Method, if I'm doing the registered trademark.
Yeah. Great question. So, like everything else, you notice a problem in your clinical setting. That's what I'll speak of. And the problem was, we were doing everything we needed to do. If someone came in and they were getting their annual physical, this is in family practice, and they had a family history, and this is years and years ago. But what do? You sent them to the cardiologist. The cardiologist would do a stress test. They passed their stress test, and then they'd have a heart attack. And it was like, well, then we've got to do something different. So the first thing we did was really understand what causes a heart attack, as simple as it sounds. What people don't realize is that it's plaque hiding in the wall of the artery. If I do a longitudinal view, the plaque hides here, blood flows here. And when someone has a heart attack, that plaque ruptures, gets exposed to the blood flow, you get a clot, and that artery is blocked. And if that blockage happens in the heart, we'll call it a heart attack. If it happens in the brain, we'll call it a stroke. And so that was the start of it. And then we thought, well, what causes plaque, right? We know there's a lot of standard things like smoking and blood pressure and cholesterol is a risk, but it was much more than that, because why has heart attack and stroke remained the top cause of death and disability from day one of records, and it still is today? And we just have to stop that. So what we focused on are, what are all the root causes of plaque development? How do we measure that plaque? How do we follow the plaque over time? And how do we follow the inflammation in that individual patient so we have the confidence to say, you're going to be fine?
And correct me if I'm wrong, but I believe I remember you talking about the fact that there are different types of plaque as well that are forming.
Yeah.
The hard, the soft, those components.
Yeah.
Is one more dangerous than the other? And is there a differentiator in what causes the different types?
Yeah, great question. So plaque is a dynamic process, right? Um, when you think about what causes plaque in the arteries, it's really driven by oxidative stress. And that could be periodontal disease, it could be untreated sleep apnea, it could be lifestyle factors, it could be remnant cholesterol, insulin resistance, all kinds of factors that drive oxidative stress, which is an important part of our body. We break down, we get stronger, right? It's important, but when there's a misbalance, that's a big issue. So what happens in the presence of oxidative stress, the smooth muscle cells in the artery get genetically transformed and they become secretory migratory smooth muscle cells. Then they release these proteins called proteoglycans, which actually trap the cholesterol in the artery wall. When it's trapped, the body tries to heal it and oxidize it, break it down. Well, that drives more inflammation.
And that's oxidative stress
Yep.
is when it's trying to break that down. Okay.
And so plaque heals over time. And what we want to do is plaque that is stable, we call it calcified or echogenic. That plaque is not going to be problematic because it's not an inflammatory process at that point. Remember, 99% of the plaque does not grow in the lumen, right? It grows here. So soft plaque or echolucent plaque is full of inflammation. So the goal of treatment is to see that plaque heal over time without more plaque forming.
Okay. Got it. And I want to talk about this a little bit more a little later because you've just published a paper around the oxidative stress component as well. But you've been highly active in dentistry, teaching, speaking at conferences. You work, I know, very closely with clinicians in your community. How did that come about, right? You're in medicine, and for a long time, there was a separation between medicine and dentistry, and not a lot of understanding about.
This is connected to the rest of the body.
Yes. But how did your transition, when did you start to recognize those connections?
Yeah. Well, like everything else clinically. So we were doing everything we could on just this one particular patient, and we couldn't get his inflammation to come down at all. Like we were doing everything. This is a long time ago. Sent him to the dentist, and he had periodontal disease, and he had a periapical abscess that wasn't known. And we thought, my gosh, we need to understand this better, because if we miss a source of inflammation this dramatic, whether it be perio or endo, we're not going to help our patients.
Right.
We can make all the numbers look so pretty, blood pressure, cholesterol, etc. And if there's inflammation that's continuous coming from the mouth, that disease is going to smolder, because I'll just speak to periodontal pathogens. When someone has these pathogens, that's gone on, think about like an ulcer, as you know this better than I, but by the time it's detected, there's already gum loss and bleeding, etc. So it's kind of like the horse is out of the barn. But why would periodontal disease be a root cause of oxidative stress in my world, in the arteries? Because those pathogens also change those cells in the artery wall to become maladaptive, the migratory secretory smooth muscle cells, because the pathogens promote angiopoietin 2, and we're off to the races. So we needed to learn a lot about that, and I think everyone did at the time. And then, we started to investigate, because we are, we don't treat an infection until we know what the bug is. So
Right.
So we learned a long time ago through Dr. Tom Neighbors and others that, you can actually measure these pathogens. That's really interesting. And so then in 2017, we wrote a paper showing causality of the high-risk pathogens and atherosclerotic development.
Okay. Now, I'm going to embarrass you just a little bit, because in October, I believe it's October, you're going to be presented with an honorary fellowship in the American College of Dentists. which is a huge deal. And I know our audience knows that, but for any non-dental people out there listening to this, that is a huge, huge deal. So congratulations.
Thank you, Greg. Thank you.
And I believe even one of our own, Laura Lee Nygaard, had a little bit of a hand in helping move that along.
She did, and I'm so humbled by this. Honestly, it just totally caught me off guard. But the nomination was submitted by Dr. Robin Henderson, and then supported by Dr. Laura Lee Nygaard and Dr. Mary Smith.
Yep.
So yeah, I'm just so humbled, Greg. I really am, and I respect the organization so much. And people sometimes say, why are you so interested in dentistry?
Yeah.
One, I'm not a dentist. I'm not a hygienist. I don't know how to treat periodontal disease. You all do. But I respect it so much that it's such a driver of arterial inflammation. And we could talk about the small guys, like the ones in the brain, whether we talk about Alzheimer's or dementia, which is all of our biggest fear, to be honest with you.
Yes. Well, it's mine, I guarantee you.
Yeah, everybody's. I respect the dental community so much. And for me to just honor that and say, those who are in the medical side who don't honor the dental side are not going to eliminate heart attacks and strokes from their practice. They will not, because it's such a driver.
100%. So you work closely with the dentists in your community, with a number of them.
Yep.
Talk to me about that process. Is it two ways? Meaning, are they sending you some people that they think you need to consult with, and vice versa? Because again, I know you've presented on this, but for our audience, talk to me about that process a little bit.
Absolutely. So first thing is I actually ask for dental records and put them in the medical chart. That's number one.
What do you mean there are 18 millimeter pockets here?
And so that's the first step of this. And then, to introduce me to their dental team. So there's that communication. But the most frequent labs that I measure, Greg, are inflammatory markers. Some have biovariability, meaning they're thrown off, like SED rate or HSCRP. They're thrown off by anything, and I measure HSCRP all the time because oftentimes I can see that the individual is probably sick, has a cold, broke their leg or whatever. But there's a couple of these inflammatory markers that are not biovariable, like they tell me something. And so by getting those regularly, it just happened to me yesterday, matter of fact. A patient came in, a young, healthy woman that I've been seeing for a long time. Overall, she's really quite stable, but her myeloperoxidase was elevated. So this is not an uncommon finding. So I called her dentist, sent her in, and Dr. Laura Lee Nygaard and Robin, everybody is like so on this, but I asked for 3D cone beam, and sure enough, she had an old tooth that was not happy, and so tools like that allow me to say, in partnership with the patient, what is going on with you? There's inflammation. We've got to figure it out.
Okay. So the real question is, a fellow in the American College of Dentists, which is a bigger honor, that or being the keynote speaker at the Seattle Study Club Symposium in January in Marco Island, Florida? Shameless plug.
Oh my goodness. Both, Greg, both.
Good politically correct answer.
I'm humbled and appreciative of both opportunities.
So let's come back to your paper now, because I want to understand more about oxidative stress and that connection to inflammation and to arterial disease, whether it's heart attack or stroke. So when you started the study to do this, or when you started to look at it, what were you looking for? And then what did you find?
Yeah, so it wasn't as much a study with individual patients. It was a summation of the literature and
Okay,
in a format
a
that,
meta-analysis or an
yep,
analysis.
yep. So the intent was to give definition to inflammation in the artery. You know, we talk about inflammation all the time.
Yeah.
You get a sliver, it's inflamed. You know, we talk about it all the time, and it's an appropriate word, I think, but we wanted to give actual name and understanding to arterial inflammation. And a better name or description of that is oxidative stress, right? So when you think about all the causes of oxidative stress, it could be gut dysbiosis, it could be air pollution, it could be periodontal disease, sleep, insulin resistance, remnant cholesterol, lipoprotein, all of these factors. There's many of them. And that when I first meet a patient, I look for all the sources, all of them, and then identify which ones we need to go after, because if we miss any of them, they all drive, and they're all connected. Like nothing is just in isolation.
No, that's the
Nothing.
big fallacy, right?
Yeah.
If I change this one thing.
Yeah. Yeah. And so, you know, if you have periodontal disease that's untreated, unidentified, it's going to certainly affect sugars, right? It's going to certainly affect blood pressure. Same with sleep apnea. You know, all these factors, they're going to drive, you know, worsening of other root causes. So it's never in isolation. But what happens is when oxidative stress is stimulated, what happens? So if you trickle down from that, you see, let's be facetious. Let's say you are the perfect human, and the only risk factor.
We're being way facetious here.
You have to think about it. You have no risk factors except you happen to live downtown Beijing where there's a lot of air pollution. That's the only thing you have. How would that cause plaque in the arteries? So I kind of mentioned it before, but air pollution is going to drive oxidative stress, and then that is going to change, like I said before, the smooth muscle lining of the artery wall. I mean, cholesterol flows through our body, flows through the artery, free flowing all the time. But in the presence of oxidative stress, let's say air pollution would be a fun example, not fun, but a good example. These healthy, smooth muscle cells become maladaptive. They become migratory, secretory, smooth muscle cells. Then they release these little proteins called like proteoglycans. Think about like a TV antenna on the roof. These proteoglycans have a negative charge, whereas ApoB cholesterol, which is a summation of all the bad cholesterol, has a positive charge. So as the cholesterol is innocently floating through that artery wall, it literally gets trapped on those lipoproteins. When it gets trapped on the lipoproteins, then we get more oxidized LDL, which is inflammatory. And then we activate the immune response and we go after it. So that's why people with like autoimmune disorders, systemic lupus erythematosus, RA, whatever it is, they're really good at this. So they obviously have a higher risk of arterial disease.
Right.
But we activate our own immune response. Then we get endothelial dysfunction, which is the very inside lining. Then white blood cells come in to try to heal that injury. They gobble up those oxidized LDL. And if we do our job right and go and look, we'll find thickness and plaque and activity in the artery wall. The same root causes of oxidative stress also affect cancer risk, lifespan, and dementia. So it's just an interesting sort of thing that we really. That's why, like, the conundrum of why are certain treatments that I use perhaps to affect blood pressure or cholesterol or blood sugars, how do they cross over and also prevent dementia, reduce cancer risk, allow our lifespan to match our health span? Like thinking about it this way through oxidative stress removes some of those conundrums that seem like a head scratch.
So is there a difference between heart attack and stroke? In other words, when you're talking about this and you're, holding up your hand and doing the artery, etc., I'm picturing near my heart.
Yeah.
And the vessels in my brain aren't that big.
Yeah. So that is great. Well, so stroke, there's a couple different kinds. What I'm talking about is a thrombotic stroke.
Okay.
You can have a bleed, an aneurysm, things like that.
Right.
I reference thrombotics, which are by far and above the most common. Okay. We have 30,000 miles of arteries. Some are no bigger than a human hair. Some are like the abdominal aorta, like 3 centimeters in diameter. Some are big, some are small. Most are small. So if you think about what causes a blockage, plaque rupture, thrombus, you don't feel the little guys, right? You don't wake up one day and say, ooh, I think I had a little blockage here.
Right.
Like you don't feel it. And so what happens is that creates chronic disease, right? It affects health of the kidneys. So it's the cause of chronic kidney disease. It affects dementia through other ways as well, lipid metabolism, oxidative stress, insulin resistance, etc. But it affects brain health. And so when you think about the human body, realize that we have 30,000 arteries and we have 30,000 veins, bringing the blood flow back up. It's amazing. And so if a blockage of let's say the LAD, a thrombus of the LAD gets blocked, and by the way, that was published in the 1980s here in Spokane, Washington, where an individual, Dr. Lloyd Rudy, and another mentor of mine, of ours, Dr. Pierre Leingruber, being cardiologist, and Dr. Marcus DeWood were 3 of the main players on that. They actually had the nerve, if you can believe this, had a gentleman having an active heart attack, and they put in a catheter and actually pulled out the clot
While he was having the
yes, dissected it on the microscope, and it was then and there that it was proven that heart attacks are caused by a thrombus, not the slow buildup of cholesterol in the artery wall. That was
Okay.
it. And they were just, the world was poof. Now it's common knowledge, but it wasn't then. And so there's some amazing mentors right here in Spokane, Washington, that changed the trajectory of understanding atherosclerosis.
Wow. Amazing. So, and by the way, we will link to that study in the show notes so that anybody that wants to take a look at it, as long as you're okay with that, we'll make sure.
Oh, the oxidative stress. Oh, absolutely. Yeah, that'd be great.
So you mentioned early on that we're still looking at the same markers today that we were looking at 20, 30 years ago. Are we better at looking at them? Or has the testing become better? Are you using new technology to give you new information? What does it look like now versus 20 years ago, just from a diagnostic standpoint?
Yeah, well, the technology has improved dramatically, as you can imagine. The technology is available. Is it used routinely? Not enough, right?
Okay.
Not enough. So the first thing to probably discuss is the idea of finding plaque and monitoring plaque. And historically, to find plaque in the arteries of the heart, it was a coronary calcium scan, which is a CT scan, very easy to get. But the limitations of that is it only measures the hard stuff, the calcification, right?
Okay.
Remember, plaque starts out as soft, and ultimately the soft plaque is the dangerous one.
Yeah, that's the one we're worried about.
Is, a coronary calcium scan is going to totally miss it. There's also a misnomer for that, and I get a lot of patients coming in here freaked out because, they find me because their provider is doing serial calcium scans. If they're well treated, what's going to happen with that coronary calcium number? What do you think?
It's going to come down.
No, it's going to go up because think about it. The treatment, like statins, and we have so many great treatments now with the PCSK9s and other treatment, it stabilizes plaque. It causes it to heal, i.e. calcify.
Got it. So you'd actually see more, not less.
Mm-hmm. And someone is healing that, you're going to see more. right? So it's not a test, and that has been proven too with different studies. You can't use that technology to follow over time because it gives one element of a complex process. Makes
Okay.
sense? The other thing I've often said is atherosclerosis is much smarter than the technology that's been historically designed to find it, right? Because the technology has looked here, whether we talk about a CT angiogram, whether we talk about a stress test, that looks here like the water through the hose when the disease actually lives in the hose itself.
Okay.
So we have technology. One that we use all the time as a surrogate is B-mode ultrasound to look at the dynamic nature of plaque healing, and the carotids have been shown to be reflective of all the arteries. So that's a very safe, non-invasive, no exposure to radiation test that remains a workhorse tool. Number one.
Okay.
Number two,
which is a simple test, and we do it at symposium all the time for
do,
folks.
and you guys are great about that. To look at the arteries around the heart, now we have technology that is AI supported. So you can get a CTA, which is designed to look at lumen diameter or stenosis. We can take those images and do an AI overlay on them and actually now see the dynamic nature of plaque from soft to mixed to calcified. So if someone, let's say, had a heart attack years ago, we're treating them, we're following them here, and they're looking better. If we look here, we should see all that plaque completely healed and calcified.
Okay. So, what about things like, and I'm going to butcher the names, but they're full body scans, Dopplers or whatever they're calling them, and other things that are now being promoted in healthcare and in medicine. Are those helping at all? Are they worth doing? Or should you wait until there are symptoms? Talk to me a little bit about that.
Sure. The one that people talk about, like the full body MRI, that is not in my wheelhouse. What is in my wheelhouse, though, is full body DEXA scanning, right? Because we have bioimpedance scales in body, other home scales even that tell you percentage of body fat, hydration, central weight gain, and they do a pretty good job, but they're not accurate. They're consistent, but they're not accurate. So,
like a personality test.
Yeah. So what I use, and I have the scanner here in the clinic, is full body DEXA to look at bone density, the whole body, and also from a cardiometabolic standpoint, look at the visceral adipose tissue in area, volume, and mass. Because as we humans build that deep, dangerous belly fat, it carries its own metabolic properties. It becomes its own organ, demands blood supply, releases cortisol. It's a thing now. It's a thing. So, the nuance of some of the new insulin resistant drugs and diabetic drugs like GLP-1 agonists, they really, if used properly, have a place in cardiovascular disease prevention, insulin resistance, autoimmune, fatty liver disease. They're misused sometimes, but they have a place in my world because they are a massive pleiotropic anti-inflammatory weapon, right?
Okay, so there is a role there, but let's talk about that for a second. When you say used correctly, whatever it is, GLP-1, the GLP-1, GLP, whatever they are.
Yeah.
What's the proper use of those? Obviously with a physician, with your actual physician, not an online physician.
Yes. And the actual med itself, let's mention that. But it's also proper monitoring. So if I have a patient on those, and I'll mention what I use them for more specifically, I regularly get the full body scans because what we want to do is we do not want to lose any muscle mass.
Well, and there's a bone density issue too, which the DEXA is doing, right? It
improves bone density, which is I'm not really talked about enough. So we use it to make sure the patient is getting healthier, meaning more muscle mass, and Yeah, it's fascinating. But
I want to make sure I heard you correctly, though. Did you just say, and maybe I misheard, that the GLP-1s, and you can tell me which one, we don't have to name product names, but it can be compound versus
Mhm.
non-compound,
Yeah,
blah, improves bone density?
yeah, yeah.
Okay.
So when you look at osteoclast activity, it's going to downgrade that, and it's going to improve osteoblast activity. So I'm the two compounds that I use are tersepatide and semaglutide. Um,
Okay.
there are more coming down the pike, but my use has been those. And the interesting thing, Greg, about these, I was anti these big time when they first came out because they were marketed literally for weight loss, which I don't agree with that.
Yeah.
Because it's unless someone has the proper coaching and lifestyle envelopment, the weight's going to come back. But when used in a patient who is inflamed, a patient, even now looking at heart failure, it actually protects, it's cardioprotective. So even someone who's had a myocardial injury, like a heart attack, the quicker we can get these on board at low doses, if the patient can afford some weight loss, it actually protects the heart muscle. It reduces fatty liver disease. That's why it has that indication. It affects the muscle cell, right? It affects that SIRT1 pathway of the muscle cell. So the muscle cell is more likely to use the insulin. So it improves insulin resistance. It protects the beta cells. And it also, through thermogenesis, removes the deep, dangerous belly fat. So it definitely has a place in my world.
Okay. Brilliant. You're presenting at symposium. I've seen you present obviously dozens of times. So I know, well, I don't know what you're going to talk about this time. I know roughly sort of your core component, but based on what you teach, based on what you know, what regardless of if I'm thinking about our audience, regardless of age, gender, occupation, what should I be looking out for? What should I be doing? Is there recommended testing? Do you recommend DECA testing across the board? Is that only if there's a symptom or at a certain age? Talk to me about just almost practically, if I were not a clinician, what should I be thinking about over the next 6 months to a year from wanting to get a handle on this?
Yeah, excellent. So the first thing is realize that every human is vulnerable to atherosclerosis. And we should not wait until someone has a heart attack or stroke or, God forbid, dementia, to wait to be diagnosed. So know that testing is available. The carotid IMT is a wonderful place to start. Understand what your cardiometabolic risk just is physically. Like, go get a full body DEXA scan. Look at your visceral adipose tissue in area. And if it's over 100, really think, that's going to drive my diabetes risk. Use monitors such as a CGM that you can go buy at Costco. Understand what your sugars are doing, the volatility. When you get your regular cholesterol checked, ask to get inflammation checked as well.
Okay.
Because it's easy, it's cheap.
And that's not normally checked unless you ask for it.
I wish
Okay.
it was, but it's not. So simple ones like HSCRP, LPPLA2, those are very simple. And those two alone are going to give a pretty accurate picture of what's going on. We use more, but those two in particular. We have been measuring lipoprotein A in patients for 20 plus years. It's not a new risk factor. The only reason the American Heart Association is now talking about it is because there's drugs now in stage 3 clinical trials that are going to lower it. But it is a genetically driven lipid abnormality. It's found on chromosome number 6. Everyone should be checked for it. It has a prevalence of about 23%. So if you don't have it, you're not going to get it. But if you have it, it increases your risk for atherosclerosis. It increases your risk of aortic valve calcification. And it also increases your risk of being really, really good at clotting. So just the simple things can be done. Do you have plaque? Are you inflamed? And getting a coronary calcium scan is not a bad thing, but I wait, someone's got to be really over age 50 for it to show up. And a score of 1 is just as concerning to me as a score of whatever, because we don't know. It's like an iceberg. That test can only tell us the tip of the iceberg.
Right.
So we don't know what's underneath the surface. So it's not a bad test, but it just tells us one element of a complex process.
So regardless of age, and I'm assuming we're talking about people roughly over the age of 30 or 40, like at 18, they probably don't need to get a carotid IMT. But that would be the place to start. Almost any physician can do the carotid IMT.
Well, that's the problem though. Not every physician, they can, but it's the protocols because we're looking at the wall of the artery in millimeters. So use a company that has the validated tools to know it's reproducible. So I use an outside company. So, and yeah, there's several of them. I'm real familiar and have used CardioRisk for years.
Okay. If you're willing, if you have a list of those organizations or those companies that people should look at, we'll definitely post that in the show notes for everyone as well. But that would be a starting point. So my carotid shows a little risk. What's the next test I should take?
Inflammation.
Okay.
Inflammation. And then if you think about all those root causes I looked at, get into the dentist,
get in to see your dentist. Yeah.
Get in to see your dentist like yesterday, like go in. If you have any root canals, ask for a 3D cone beam to know there's nothing going on hidden there that you can't feel. Get pathogens checked if you have the opportunity. See your dentist more than every 6 months, period. Every 3, it's a good insurance policy, and all my patients see their hygienist every 3 months. I'm a huge advocate.
3-month recall. Okay.
Yeah, that's another place to start. And then when you think about all the root causes, know what your cholesterol is. There's ratios that can be identified as risk, like total cholesterol to HDL, triglyceride to HDL. Those tell a big story. Get lipoprotein A checked. Do either a glucose tolerance test or see what's going on in real life. If your spike of sugar should never, ever be over 200. If it's over 200, you're probably diabetic, by the way. What we look for insulin resistance is to make sure it doesn't really go over 125. And it's more like this volatility. So it's an early indicator that someone might have risk. And yes, have a blood pressure cuff at home. Check your blood pressure every morning. Get assessed for sleep and airway.
Checking my blood pressure every morning would stress me out.
That's a good point. The more you do it, the less that angst goes away. We all think it's a test. So measure it all the time. And then once you lose that guard, then get it twice a week in the morning and maybe in the afternoon. And it should be less than 120/75. That's the better goal.
Okay. Less than 120/75.
Yep.
Okay.
On average.
So I'm super excited for you to come to Symposium. You're going to be with us for a number of days. I don't know if you've committed to staying with us the whole time yet or not, but awesome. We'd love to have you there. You're doing a program for everyone, a keynote, then you're going to do a workshop. But I love that you're going to be with us throughout the week so that if people want to connect with you, and obviously from your standpoint, you're going to be listening to some phenomenal presentations and folks in the dental field and around it as well. There are 2 books currently. Put you on the spot. Is there another one coming?
No, it's like giving birth to an elephant. No book coming. Beat the Heart Attack Gene and Healthy Heart, Healthy Brain. But even from that last publication, we're learning more. And I'm going to come to your conference and I'm going to learn so much because, I want to do better tomorrow than I did today. I want to, the more I learn, the better I can provide care for patients. So I think that's what keeps it exciting for me. The more you know, the more you don't know, basically.
100%. And honestly, I think that's what keeps it exciting for all of us. There's that symbiotic relationship where we're learning from you, you're learning from us. There's all of this back and forth happening, and there will be people who are presenting things and you'll go, oh, whoa, I think that's way out of bounds. Or, wow, I never thought of it that way.
Yeah, for sure.
But that's the idea. Let's bring the stuff to the table, and people will sort through what works for them, what has validity and what doesn't. So,
One thing, I'll just throw this out there. Part of my respect for dentistry is how complex the infections are. It's easier, like if I diagnose strep throat, well, I know exactly what's going to treat that, right? If someone comes in and has a UTI, I'm going to do a culture and sensitivity. I'm going to know what bug is causing it. I'm going to treat that one bug. These are one bug diseases, right? Or infections, I should say. The complexity of the oral pathogen arena, and then you throw in gut dysbiosis, you put all that out there, and it's so complex. So over my years of learning, everyone has different ways of treating it. There's no standard, I've learned, and that's probably good. But I think we need to respect how complex of an infection periodontal disease is. It's not an easy fix, and I respect that.
Amen. I appreciate you, and really excited to see you in January. Hopefully, maybe I can make it over to Spokane and we can go out to dinner before then. So
love that. You could get some scans.
There you go. I could probably use them at this point. So, and cheers, my friend. I'm looking forward to seeing you.
Can't wait to see you.